Everyone. Welcome to Virtual Morning Reports, the RLR edition. There's only one R now, but the other is on his way. He's actually post-call, is on service in his post-call. But we will proceed with extreme excitement today because you'll notice that, well, actually, the CP Solvers team members immediately recognized who would be presenting a case. Kiara, can you tell us how you figured it out? How did you know who was presenting a case today?
He's dressed very elegant. And it's Kirtan.
Yes, whenever Kirtan presents a case, he puts on a show, both with the case presentation, but also his decor. And when Kirtan is wearing a fancy shirt, he's here to teach us. So Kirtan, do you want to say hi, introduce yourself to the crowd? And we'll get going right after.
Yes, hello everyone, good morning. Myself Kirtan. I am from India and I am from the state of Gujarat, which is in the western part of India. And I just wanted to have one brief reflection that I alluded to a few days earlier to Maria and other team members, that sometimes when you work with Rabi and Reza and people are so kind and so generous that you kind of forget that how amazing and great they are. So I just wanted to say that every time I get a chance to present a case, or every time we witness their clinical reasoning, so deep inside, I feel very, very fortunate because not many people have that privilege, and we don't realize that because they are so kind and they are so like friend-like, but indeed it matters much more than that. So that was my reflection. And also I wanted to share with everyone that I am, feeling a little bit down today. I am having a cold. So in case I sneeze, then please excuse me in advance. I have my tissue paper here. But if anything goes wrong, I have even sent the case to our scriber, Gabriela, so she can continue presenting. Meanwhile, I can recover. So thank you for that. So excited for today's case. And now back to you, Rabi.
You're so incredibly sweet, Kirtan. That's very, very kind. I don't think you should worry because Rafa is in clinic ready to take care of you anytime you get sick. I think at least he's in clinic. I don't know where he is. Hi, Rafa. Good to see you, my friend. All right, Kirtan, Reza will join us momentarily, but maybe you and I can kick off the case and go from there.
All right. So the title for today's case is Dangerous Discoveries. And just to make sure, dangerous discoveries, all right? And since it's a long case, I will fuse the first and second record. So the chief complaint is fever. And H for the HPI part, we have a 34-year-old male who presented with the history of fever since 1 month. Fever fluctuated between 99 and 102 degree Fahrenheit. There was no particular pattern for fever that patient could recognize. Fever was occasionally accompanied by night sweats. He also endorses yellowing of the skin and sclera since last 3 weeks. He complains of dysphagia, odynophagia, dyspnea, nausea, vomiting, and malaise since 2 weeks. 2 weeks back, he went to a local clinic for fever where he was given non-steroidal anti-inflammatory drugs, to be precise, nimesulide, for his fever. He then developed a generalized maculopapular rash which persisted despite discontinuing the nimesulide. And in fact, as per the patient and her wife, the rash worsened even after discontinuing the nimesulide. As for the review of system, the patient denies weight loss, diarrhea, chest pain, recurrent falls, dizziness, headaches, or any back pain. And that's the end of Aliquot 1.
Ay. Man, it's like, it's like, feels like round one, just inundated with information. And if you're trying to be systematic about solving this, I think the way this case is colored, it is completely tethered by the presence of fever. Why? Fever is the most specific sign for inflammation. And the journey that we go on when we're on fever is to, on our first evaluation, prioritize infection and prioritizes the 3 H's: hyperthermia, hyperthyroidism, and hematology. And then that's the lens we're going to use. And then we start to filter in what other clues do we have to prioritize where the infection may be and the other 3 H's. So here we have jaundice. Actually, we don't. We have yellowing of the skin, which typically implies jaundice. And jaundice can map onto a hematological issue like a hemolytic anemia, causing indirect hyperbilirubinemia, or a hepatobiliary issue causing direct hyperbilirubinemia, and both of those can cause fever. The other feature that we have that's even more unusual than jaundice is the presence of odynophagia and dysphagia. So odynophagia and dysphagia can represent essentially difficulty with swallowing, which is divided into two categories. When you swallow, there's really two sections of the swallow process. The first is when you move something from your mouth to your esophagus, and then when you move from your esophagus to your stomach. Those two have entirely different differential diagnoses. Odynophagia tends to be a very noisy dysphagia. Most people with oropharyngeal dysphagia have cough, gurgling, nasal regurgitation. They have a lot of trouble. So if somebody is telling you, hey, doctor, I have trouble swallowing, and that is the end of the story, it is probably esophageal. Most patients with dysphagia that is oropharyngeal, like, I can't move it, I cough, I drool, something comes out of my stomach. So the fact that there's dysphagia here without much color to the story tells us it's probably esophageal. The odynophagia suggests that there's something in the esophagus irritating it. So what are the long list of things? They can be strictures, like from peptic ulcer disease, webs, rings, and ulcers. And when the patient is having pain, you probably would prioritize esophageal ulceration, be it peptic ulceration or infectious ulceration from things like HIV, HSV, or Candida. So where are we at? We have a complicated syndrome that involves the esophagus, very likely, either inside the esophagus and the esophageal wall or on the outside. We don't know if it involves the liver or the hematological system yet, and also involves the skin. The most common cause of high fever and skin inflammation is a drug reaction, but here there are no culprit drugs. There's a drug in the mix, but it was actually started in the middle of the syndrome. And so there's not much progress I think we can make now, apart from trying to clarify all the things we want to follow. Is this jaundice hepatic or hematologic? Is this odynophagia an ulcer or a stricture? And of course, being open to the data that we haven't studied yet. What is the nature of this inflammation? Is it funky in any way, shape, or form? Is the kidney involved? Are the muscles involved? Is the electrolyte system going to give us some clue? So there's a lot of studying. I would sit back, study the liver versus heme, study the esophagus, study the skin, and wait for other defining features of this illness to emerge. All right, Kirtan, back to you. Well, for some reason it was, I think we lost you for, I don't think we heard you until now. It just came back on.
Yeah, it's fine. Now can you hear me? All right. So as for the past medical history, the patient has HIV. It was diagnosed 1 year back, and due to the financial reasons and certain other aspects, which I will come to later on in the case, the patient has not been on any antiretroviral therapy. As for the medication, so as I told you, the patient was on nimesulide, but that was subsequently discontinued and the patient is on no other medications. Family history is non-significant. As for the social history, the patient denies alcohol, tobacco, or illicit drug use, and the patient has no allergies. And Ravi, do you want me to stop there or should I give a physical examination too?
I see Prof. Rez is here sipping some coffee. So
yeah, let's introduce him. Yeah.
Maybe you can give him the medical history and the exam to work with. How about that?
Hey, Prof. Rez, how are you doing today?
I am doing better that I'm hearing your beautiful voice, Kirtan.
Yeah, it's not so beautiful. You know, I am feeling the cold, so you can feel that hoarseness in my voice for sure. Yes. Yeah, so actually the title of the case is Dangerous Discoveries. And in fact, in every aliquot, you will find one that dangerous thing. So that was I titled it as Dangerous Discoveries. So basically we had a patient who had, fever, jaundice, and lots of symptoms. The patient has dyspnea, lots of vague symptoms. As Rabi told us, we can't zoom in. And the patient even has this rash thing. Initially, it was thought that maybe it was due to drug, but now the drug has been discontinued and still the patient has this rash. And interestingly, the patient doesn't has weight loss despite the past medical history of HIV. So that's to summarize. The patient had lots of things, non-specific thing, and now we are here. And so, do you want me to give this physical examination too? All right, let's go ahead. So as for the vitals, the patient is febrile with temperature of 39 degrees Celsius, the heart rate of 102 beats per minute, the BP of 118/78. The patient is saturating at 94% on simple oxygen mask. And why the patient is on oxygen mask, I will let you know later on. The respiratory rate is also increased at 22 breaths per minute. As for the general appearance, he appears ill and uncomfortable. The patient could barely speak. In fact, most of the history and everything, I got it from her wife. As for the head and neck examination, the pupils were round, reactive, and reactive to light. There was presence of white plaques in the oral cavity. The oral cavity was dry, and the tongue was also dry with prominent furrows on it. As for the abdominal examination, there was no evidence of rebound tenderness, rigidity, or guarding, but the spleen was palpable. As for the cardiovascular examination, there was no evidence of murmurs, normal S1 and S2. As for the pulmonary examination, he was quite dyspneic, and there was evidence of diffuse crackles throughout all the lung fields. As for the extremities and skin examination, so now there is new thing. We have generalized pitting edema of the lower extremities, and subsequently over the course of hospitalization, it spread to arms and trunk. So edema, pitting edema over the extremities as well as trunk, both upper and lower extremities. The maculopapular rash is also present. It is pruritic and it spares the palms, soles, and face. Apart from those three regions, it is present everywhere. As for the mental status, the patient is alert and oriented to time, place, and person, and there is no evidence of knuckle rigidity. And that's the end of aliquot 3.
Wow. What a presentation, Kirtan. I'm very worried about this patient. And I think that there's just so much data here, meaning so many findings that can serve as a center of gravity, that we have to step back and try to make this as simple as possible. And I will start with a discussion, but I would love Robbie to fill in any gaps and to add, because I really think two clinicians will approach this case differently. And it comes down to like what you're comfortable for and what you identify as your center of gravity that you want to build your DDX around. Because let's be honest, if this patient just had jaundice, our whole focus would be the jaundice. But for me, the center of gravity, meaning the foreground, as Ravi likes to say, is the fever and rash. Fever and rash. The background is HIV infection, meaning fever and rash in an immunocompromised patient without adequate CD4 cells, without adequate lymphocytes. That's the background. So when we go through the fever and rash, you have to consider causes that are not related to an immunocompromised status. Then you enlarge your scope to incorporate causes related to an immunocompromised status. So actually, I have pulled up our fever and rash schema. Let me just share this with y'all so you can see in real time like how I would approach. Actually, you guys can pull it up yourselves. Just go to fever and rash clinical problem solvers. But I have this pulled up. And this is what you want to serve as your center of gravity. And I think priority number one is to get away from trying to find one diagnosis in this patient. This is not a patient, despite being young, that you apply Occam's razor. This is a patient where you apply Hickham's dictum, meaning this patient can have multiple diagnoses. When you're immunocompromised, you're not only at risk, at a heightened risk of typical infections, you're at an increased risk of opportunistic infections, and you're at an increased risk of opportunistic malignancies. And you're at an increased risk of multiple infections happening at once. So right away, we need to know whether this patient has been compliant with their antiretroviral medication therapy by assessing their CD4 count, their lymphocyte subsets. You can make a prediction based on the absolute lymphocyte count, but as you make that prediction, you still want to know exactly what is the CD4 count in this patient. Fever and rash, what are the life-threatening causes that you can't miss? Meningococcemia, toxic shock syndrome, necrotizing fasciitis, endocarditis. These are the life-threatening causes you can't miss. Now, this has been going on for 2 weeks, which may lessen the likelihood of one of these robust, acutely fatal rashes like Rocky Mountain spotted fever. Because if you don't treat it within 2 weeks, it can be fatal. Same with meningococcemia, though you must consider it. You may say, why would you even think about toxic shock syndrome? He's not hypotensive. You don't necessarily need to be hypotensive to have shock. So we're going to be interested in the end organ function, the creatinine, the urine output, and the lactin to see if we can frame this as shock. So now that we're thinking about fever and rash, recently I love what Robbie did on a recent RLR where he said, use the IMAID mnemonic, but in this case, you can capitalize the D, though in this case, we will still keep the I capitalized, Robbie, because we're worried about it. So you can then break down infections into viruses, bacteria, and fungal infections. Viruses and bacteria, if you apply the base rate disease, are the most common, okay? What kind of viruses? Well, these can be some of the exotic viruses, but before we even talk about that, let's talk about the common stuff. The stuff that causes infectious mononucleosis. These are the herpes viruses, which include EBV, CMV, HSV, as potential etiologies. So like when you even think about that, could this be CMV? Of course it can be. CMV can involve the lung. CMV can cause a macular and papular rash. CMV can involve the liver, and it can present acutely like this. And the patient is immunocompromised. So I think CMV is something we must consider. So you will obtain a CMV PCR, and ultimately it can be a tricky diagnosis where you actually have to show pathology you have to actually identify the organism causing pathology within an organ. So CMV and infectious mononucleosis is up there. I didn't get a sense that this patient has traveled. I actually don't know where they're located, but chikungunya, dengue, and Zika can all cause this type of rash. Measles in the right patient also can present in such a fashion, as can varicella, which you have to consider. Bacterial etiologies, I think to include here would be syphilis. Syphilis can cause any type of presentation. It can involve the skin, it can involve the liver, but doesn't necessarily involve the lungs. So making that less likely. Mycobacterial infection often doesn't have such an acute presentation, so incorporating the tempo, but you have to think about it. Much higher risk for mycobacterial infection, especially if the CD4 count is low. There are few infections actually in patients with HIV where their risk increases despite CD4 count. One of them is Candida, which this patient may have oral pharyngeal esophageal candidiasis despite a normal CD4. And another one is mycobacterial infection, so still at risk. So I would be concerned in such a patient, I would isolate and work them up for AFB on their sputum to protect everyone else, because mycobacteria can involve the liver, the skin, the lung, and this patient's at an increased risk for that. I've just talked so much, I could keep going on, but let me just pause there and pass the mic to Robbie so he can pick it up and go with it and sort of speculate what else I was thinking.
No, I think, yeah. I don't have anything to add. I think that was a great overview of the infectious possibilities. I'm just going to be authentic. What I'm doing now is I'm like, this patient is inflamed and they're immunocompromised. And I'm trying to do two things: tracking which organs are involved, lungs, liver versus heme, skin, spleen, Skin in two ways, the edema and the rash. And that's it. Because in real life, if I was meeting this patient, I would be still in the problem clarifying mode. I would not be trying to solve this problem as it is too complicated. I would be listening to what Reza said for tests to order, but I would still not be trying to solve this problem. The question is, what is the equation here, not what is the answer? And the only way to do that is to never lose track of all the things that you're going to eventually make simpler and simpler and simpler. But there's one other thing here. And I'd emphasize what Reza said. You have to be open to multiple diagnoses here. The solution to the problem may be multiple answers. Unlike step 1 or step 2, it doesn't have to be A, B, C, D, or E. It may be all of the above. So those are the two things I'm doing. Making the problem digestible by now trying not to solve it, but rather to clarify it. Lungs, skin, spleen, liver versus heme. Make sure that I haven't closed my mind to the possibility of multiple answers. And I'll tell you, the odds are this patient has multiple answers simply because most common cause of esophagitis is Candida, and Candida doesn't do this. So he has an overwhelmingly high chance of having multiple things going on. All right, Kirtan, back to you.
Yes. So this is going to be a long aliquot. And as you suspected, everything is involved. So the hemoglobin is low at 10 grams per deciliter. You can hear me, Ravi, right? All right. So hemoglobin is low at 10 grams per deciliter. The MCV is 78. The WBC count is 7,000 with normal differential. And since the patient has been admitted for last 15 days, we have repeated all the counts and all the labs, and all the labs have been consistently showing the same report that I have been mentioning here. So throughout the course, patient's WBC never went below 4,000, and the CD4 count was also normal. The absolute lymphocyte count was 2,700 cells per millimeter cube, which is also within the normal range. The platelet counts are low at 25,000. The direct Coombs test was positive. On peripheral smear, there was no evidence of cystocytes or malarial parasites. As for the basic metabolic panel, the patient has hyponatremia with sodium of 125, potassium of 4.9, blood urea nitrogen of 122, creatinine of 3, AST is elevated at 415, ALT is elevated at 224, alkaline phosphatase is elevated at 260. Total bilirubin is 15 grams per deciliter, direct fraction being 12 and indirect being 3. The total protein is low at 5.4. The serum albumin is low at 2.4. Albumin is 2.4. Serum cholesterol is 135. Serum triglyceride is elevated at 1058, so 1058. HDL and LDL fraction are normal. The INR is elevated at 2.2. APTT is normal. The procalcitonin is within the normal limits, so it is 1.55. The CRP is elevated at 3030. And since the patient has been suffering from fever since 1 month, extensive infectious workup was done. So the serologies for dengue, chikungunya, typhoid, brucella, hepatitis A, B, C, D, E, CMV, toxoplasmosis, rubella, histoplasmosis, tuberculosis. All of these were done and all of them were negative on multiple occasions. As for the chest X-ray, there was evidence of diffuse infiltrates consistent with the diagnosis of ARDS as per the pulmonology. And actually this is where I was called. So basically lots of residents, are my friends, and now I have graduated, so I don't have access to patients. But whenever they come across a rare case, they're like, Kirtan, you might want to lay your eyes upon this. Maybe you would love it. And they have told me that this patient is dying and maybe you can help us. I was like, I don't think I can help you if the patient is dying and this severe, but maybe I can come and take a look at it. So here is where I was asked for looking at the case. And then I subsequently ordered 4 tests, which I will give you in the next report. So as of now, what are your thoughts?
I don't know if you need us, my friend. I really don't. But I just want, maybe what I can do is to try to clarify what has changed. How has our understanding been enriched by this? We've understood that the hematological system is affected by the fact that there is anemia and thrombocytopenia. We also understand the nature of that hematological issue because there appears to be a destructive component of that anemia and thrombocytopenia. The strongest evidence for that is that the Coombs test is positive. Now, there can be a false positive Coombs test, but it's only false positive in a small fraction of patients. And given the concomitant thrombocytopenia, it's hard not to wonder that this patient has both an autoimmune hemolytic anemia and a thrombocytopenia. We also understand the nature of the bilirubin, and the nature of the bilirubin is that there's almost certainly a hemolytic component to it with the indirect hyperbilirubinemia, but there's also a prominent direct hyperbilirubinemia with implicating the hepatobiliary system. The AST being higher than the ALT also supports that there's a hematological process superimposed on the hepatic process. So I'll pass the mic to Reza to see where his thoughts are at, but I feel like now this is a febrile syndrome that involves the skin, involves the lungs in a diffuse pattern, has a component of a likely autoimmune hemolytic anemia and thrombocytopenia, and involves the liver, intrahepatically or extrahepatically, we don't know yet. So I think that's now the problem we're trying to solve. We're getting closer and closer to the nature of the problem. But I'll pass the mic to Reza to reflect more on that.
Robbie, one thing that I love that you're doing is like listing out the organs that are involved, because it really helps frame this complicated case that Kirtan is presenting in a patient that's spiraling downwards rather rapidly. And I still am using as my center of gravity a febrile syndrome with a macular and papillary rash. That, in my opinion, has to be explained by the final diagnosis and will prioritize my DDX with the background of HIV. And so when I say that, like if we go back to the DDX that we were creating, and let me just pause there for a second, because there's something that reflexively came up for me as I listened to Kirtan present this. But then the only reason I pause is because I think there's multiple diagnoses at play. Robbie already mentioned one, being Candida. Most likely this patient has Candida. But another one is when you see a sodium of 125, you see a sodium of 125 in a patient who has HIV, and you couple that with a normal diff on the white blood cell count. I know Kirtan didn't specifically said the eosinophils were normal. You have to consider adrenal insufficiency. It must be considered as a common cause of primary adrenal insufficiency. I know the patient isn't hypotensive. I know the patient has a fever, but it's something that needs to be assessed for emergently, is adrenal insufficiency. Then when you say hypertriglyceridemia, that's quite high. And there are various causes for hypertriglyceridemia. This patient is quite young. I can't see any obvious medication culprit. So when you say hypertriglyceridemia, HIV, anemia, thrombocytopenia, splenomegaly, it just makes me think of HLH. And when I think of HLH, I think infectious mononucleosis. So again, the EBV and CMV, specifically the CMV, given the immune status of the host, or an undiagnosed lymphoma. So I think an LDH will be important. I think the viral PCRs will be of paramount importance because I'm very concerned for infectious mononucleosis in this patient, specifically CMV. But of course, I'll treat this patient with broad spectrum antimicrobials because they're at heightened risk for typical infections as well. So Robbie, I'll step back and pass the mic back to you to see what other thoughts you have. But honestly, like I am thinking sepsis. I'm thinking viral infectious mononucleosis. I'm worried about HLH. And I'm also worried about adrenal insufficiency and oral pharyngeoesophageal candidiasis.
I absolutely love that. This inflammation got real funky on us in this aliquot. And it's funky because it is a pattern of HLH. And I think the dimension to study HLH with is to ask like what complication can occur in a patient with HIV with a normal CD4 count. And the most common complications of patients with HIV with a normal CD4 count are malignant. The malignancies are primarily lymphoma. So I think if you analyze this case from two dimensions, you're like, I worry about Reza made a very compelling case for HLH. The most common causes of HLH are malignant in nature, and the most common causes of severe complications in HIV with a normal CD4 count are malignant in nature. But as Reza reminded us, just because it's the most common doesn't mean it's the most morbid. Make sure you think about the infectious trigger. So I am right there with you, and I'm trying to guess actually to play the game with Kirtan what the 4 tests he sent, and I'm hoping that at least one of them is the ferritin.
Yes, sure. So basically the reason why I mentioned that, because you know that we work in a resource constraint setting. So often it happens that we are not, allowed to do the fancy test because it can be so expensive, and some of them are not done in our hospital. So we have to send it outside. So we have to be cautious about the test that we order. So my resident told me that give them just order basic tests. We won't be able to do any funky tests. I was like, okay, let's start with the basics. So first we ordered the USC, and in the USD there was lymphadenopathy in the bilateral jugular chain with the largest lymph node being 17 by 5 millimeters. And in all cases, the fatty hilum was preserved. There was lymphadenopathy in the submandibular region, bilateral inguinal region with largest one being 18 by 7 millimeter. There was evidence of splenomegaly, as the Travis alluded in the chat, and even you and Reza wanted to ask about that. So splenomegaly was present, the largest dimension being 17 centimeter. There was evidence of hepatomegaly too, with largest dimension being 15 centimeter. There was evidence of slight pleural and ascitic fluid. Then there was fibrinogen. So fibrinogen was low at 84, with normal range being 200 to 400. So there was evidence of hypofibrinogenemia. And then ferritin. Finally, the ferritin comes, right? So the ferritin was elevated at 14,896. So as you know that, what are now your considerations? I think it is HLH, it's clear, but I just wanted to make sure that if you have any comments.
I actually would love to just hear Ravi comment on this data. Ravi, what do you think, my friend?
Thank you. That's very kind. I think we've nailed the diagnosis of HLH, but nailing the diagnosis of HLH is no different than saying the patient has eosinophilia. It just tells you the nature of the inflammation, and your job is to still be like, well, why does the patient have eosinophilia? Why does the patient have HLH? The most common cause of eosinophilia in the world is parasites. The most common cause of HLH in the world is malignancy. But here we also have another dimension, which is lymphadenopathy. And I'll tell you that the chances of you getting this diagnosis without a biopsy are very low. And the reason that is yes, you can avoid doing a lymph node biopsy by getting EBV serologies and looking for mycobacterial or fungal causes of lymphadenopathy. You can get a positive ANA. You can look at the medications and make sure the drugs are involved. You can also get an SPEP to make sure that there isn't a rare cause of lymphadenopathy like amyloidosis. But here, the truth is you probably have to take that lymph node out. And the lymph node, unfortunately, the presence of HLH doesn't help you prioritize which kind of malignancy, liquid malignancy. It can be any lymphoma and any lymphoma adjacent. So I think the name of the game here is to take out that lymph node and study it. That's where I'm at. I'm curious, Reza, what would you layer onto that? Or what are your thoughts?
I have zero to layer on, but I see our dear friend Fernand is in the chat. And I would love, Fernand, if you're in a place to unmute yourself and just give us your impression from a hematology standpoint. Like, what are you doing for this patient?
Yeah, hi, how are you? This reminds me of a few cases that I've seen a few months ago, and bizarrely enough, like patients come with fevers, a sepsis-like syndrome. They are in the ICU sometimes with multiple organ failure and some hemodynamic instability, and they've been on antibiotics, nothing's growing, and you can't go anywhere, and the organ dysfunction is getting worse. So this is when we start getting called for cytopenias that are developing. And I always think of HLH on the differential when there's a sepsis picture without a clear dysfunction. I just want to highlight something Aaron Goodman from UCSD tweeted about recently. There's a nice paper, I think, in a journal that he tweeted about recently. It's a review with a good graph on how to approach HLH and when to start choosing chemo and steroids. So most of these patients that I've seen, I remember like a good thing to send is an EBV PCR, because EBV is a trigger of a lot of HLH. Obviously, in a HIV patient, you can also think about CMV, other viruses you can send. And when we see it positive, like we're really chasing lymphomas that are EBV positive, be it Hodgkin's or non-Hodgkin's lymphoma. And we always think of Hodgkin's being a really indolent disease where you just have a lymph node and you're walking into a clinic. But like I've seen Hodgkin's just causing the cytokine syndrome that's uncontrollable, organ failure, with just barely some liver dysfunction, which could be paraneoplastic due to a phenomenon that we don't really understand. It's a cholestasis that's related to Hodgkin's, or sometimes Hodgkin's infiltrating the liver. I would say a bone marrow biopsy could be helpful because it might show hemophagocytosis. I do not know if we really need to send all these fancy tests for HLH. The picture is quite convincing. As long as we chase that lymph node, I think it's the most helpful thing. I would hold off on steroids until we get that lymph node out. But if there's a lot of instability, would start steroids. Not chemo, probably, unless like we have a frank diagnosis.
Bernard, let me just say your fellowship paid off, my friend. That was magical. Thank you so much for contributing on the fly. That was really special to have you in the audience. Mike, to you, Kirtan.
Yes, so actually, as I told you, I ordered 4 tests. So there are few tests still remaining. So first, as you know that I love rheumatology, so I love all the fancy criteria. So I just wanted to mention that in HLH, in order to diagnose HLH, you need 5 out of 8 criteria. And we know certain criteria, and there are certain criteria which are obscure. So what are the criteria? So we should have fever, splenomegaly, cytopenias at least in 2 lineages, hypertriglyceridemia and or hypofibrinogenemia, elevated ferritin. And then there are supportive criteria, which includes conjugated hyperbilirubinemia, transaminitis, hypoalbuminemia, hyponatremia, elevated alkaline phosphatase due to macrophages infiltrating the liver and causing compression of the bile ductus, low NK cell activity, elevated soluble CD25 levels. So if you see these 8 criteria, almost all of criteria are fulfilled. And since we are not in a position that we can order soluble CD25 levels because it's an extremely expensive test, we can't order that. But bearing that out, everything was convincing. Then we did the bone marrow biopsy. And in the bone marrow biopsy, there was histiocytes showing HLH. So in the view of bone marrow biopsy and the lab findings, there was convincing evidence that it was a secondary HLH. And now the remaining 2 tests. So I even ordered the interleukin 6 levels, which were elevated at 76. And so now what are your thoughts before I reveal the final test, which sealed the final diagnosis?
I think CMV would be high on my DDX as a trigger for the HLH versus lymphoma, Hodgkin's or non-Hodgkin's. Robbie?
Oh, what a beautiful, I think just to reflect, presenting a case of HLH is very, very hard. You see how much data there is in this case. And I think that the story being told, the dangerous story being told by Kirtan is absolutely marvelous. I'm also just like amazed that we can sit here, walk through this discussion and have the expertise of a fellow Lebanese share his input on HLH. I think it's very hard to predict cancer, and this is a cancer, or a virus-driven cancer, EBV, CMV, driving a malignancy, or it could be primary EBV or CMV, but the focus should be on cancer. And I'll share that it's actually very hard to predict cancer with blood tests. What are the cancers you can predict confidently with blood tests? PSA, if it's very high, beta-HCG in a non-pregnant adult, AFP in a patient with cirrhosis, all predict cancer very high. Serum-free light chains, when they're very abnormal, can predict cancer. But that's really it. How does an IL-6 predict cancer? I don't really know, but I do carry an association with IL-6 and Castleman's disease, specifically multicentric Castleman's disease, which is an important one consideration in a patient with HIV. So I think it's some sort of lymphoma, or it's the unwanted castle in this patient's lymph nodes. Those would be my bets.
Yes, so Rabi, you nailed it. So as we know that in our case, there are few things which doesn't fit with HLH quite perfectly. So what about the NSRK? We know that albumin is low, but still edema is too much. Furthermore, what about the lymph nodes? We know that HIV can cause lots of infection and can cause lymphadenopathy, but the CD4 count is normal. And the extensive infectious workup so far has been negative. So now what to do? So I just wanted to briefly again mention what is the criteria for active multicentric Castleman disease. So you require fever, you require raised CRP, and then any three of the following. And which are those? So we should have peripheral lymphadenopathy, splenomegaly, anemia, pleural effusion, ascites, xerostomia, which was in our case, if you remember in the physical examination, the patient had dry mouth, xerostomia, then rash, which can be maculopapular too, jaundice, and autoimmune hemolytic anemia. So all of these are supportive criteria for MCD. So it was a convincing case for MCD too. And finally, there is one rare variant of multicentric Castleman disease known as Tefro syndrome. It stands for thrombocytopenia, anasarca, F for reticulin fibrosis / fever, O, R for renal dysfunction, and O for organomegaly. So we consulted the hematology and we were like, do you think this could be MCD? Do you think this could be Tefro? And they were like, we can't be sure unless we get the HHV8 and EBV serologies. And we could do repeat bone marrow biopsy to see the evidence of reticulin fibrosis. But unfortunately, as you know that we are rapidly spiraling out of control and there is nothing we could do much. So despite all we can do, the patient succumbed to the death. And it was so sad because as I told you, the patient was so dyspneic. And ultimately that was the clue, because we, as Rabi alluded to, that when the IL-6 levels are high, that's why we get anasarca, because the capillary permeability is increased. It's like, capillary leak syndrome. And IL-6, VEGF levels, both of them are usually elevated in such syndromes. And that's why you get ARDS. It's simply the pulmonary leakage into the alveoli, which is causing the respiratory distress. And since the edema was so much, even the bone marrow biopsy was so difficult, the patient was in lots of pain. And so unfortunately, we couldn't even get the EBV serologies, but I can tell you that CMV serologies were negative. But yeah, EBV serologies could be a possibility. But again, the hematology was concerned that if CD4 count is consistently normal since lots and lots of time, it's hard to surmise the possibility of HHV reactivating, as the Fernan alluded to in the chat. So ultimately, they told us that HLH is confirmed from first bone marrow biopsy, but finally, your suspicion that it could be multicentric Castleman disease, especially Tefro variant of MCD, shouldn't be discounted, and it can be a possibility. And final thing, whenever HLH presents with hepatic failure, then it portends an extremely poor prognosis, no matter if you give dexamethasone or you give any other drug, like etoposide is also approved for HLH. But when HLH presents with hepatic failure, it's very, very rare that you can salvage the patient. So it was a sad story and it was very humbling reminder. So I realized that despite ordering tests and everything, it's not the end. You have to save the patient, right? That's the duty of doctor. And hopefully I can learn from this case, and maybe in the future, I can increase my clinical skills and maybe save some patient in the future.
Hey, Kirtan, thanks again for presenting this very rapid deterioration, very difficult case, and a young person. Very, very sad. Did this person get dexamethasone? Did that discussion come up?
Yes, so actually he was on, initially they were very reluctant because, in HIV, we always worry that what if there is some infection that we haven't yet get hold of, and what if giving dexamethasone would just blow it off. But still, in the end, the patient was suffering so much. So the patient did receive dexamethasone for 5 full days before the patient was no longer with us.
Okay, well, so sad. And but thanks again for presenting this. I think a lot of teaching points here, but I'm not sure that there could have been anything done. It was just too rapidly, progressive and fatal.
Yeah, I completely agree. I think it's just so unfortunate. And this is a reminder of so many things, but a reminder that patients with HIV, even if their CD4 count is normal, they have immunological dysregulation that can result in diseases that they can succumb from. So this is more and more why there's more a push to start antiretroviral therapy at diagnosis with HIV. So more and more, I think we all have to unlearn the association of, oh, what's the CD4 count? It's helpful, but patients can have devastating diseases with normal CD4 count. And this is a great example, unfortunate one, but a great example of that. You cannot be comfortable with HIV when a patient has a normal CD4 count. So thank you for that, amongst many other reminders, which I know that Vale will remind us of. So pass the mic to you, Vale.
Thank you. Thank you for the case. Kirtan was amazing as always. And so the chief concern was a fever for 1 month, and Roy reminded us of prioritized infections. And then when we found out that the patient also had jaundice, we were thinking about, is this a problem of hemolysis or something occurring in the hepatic system? And then the adenophagia and dysphagia made us think of the immune status of the patient. This could be candida, this could be a case of Hickham's dictum. And also, Robbie mentioned that dysphagia with adenophagia was a sign of esophagus irritation, which could be strictures, webs, rings, or ulcers. And then the generalized rash, Reza reminded us of the life-threatening causes of a rash, which include meningococcemia, Rocky Mountain spotted fever, toxic shock syndrome, endocarditis, and necrotizing fasciitis. And then some red flags to consider in a generalized rash are fever, mucosal involvement, pain, and medications. And with fever, we made a Venn diagram of fever and rash, in which we include infections, prioritizing viruses, especially because the patient was living with HIV, and then bacteria and fungi. And Ravi mentioned this great pearl that patients that have a CD4 count normal, they can have complications of HIV, in which the most common is malignant, and in the infectious category, you can have candida and infections of mycobacteria, even if your CD4 count is normal. And then the other categories of fever plus rash include drugs, malignancy, and autoimmune etiologies. And then the hemophagocytic lymphohistiocytosis, or HLH, which is basically a diagnosis by criteria. And the pearl here was that heme malignancy in an adult patient with HLH should be the priority and antiproven otherwise, and includes criteria such as fever, splenomegaly, liver damage, hypertriglyceridemia, hypofibrinogenemia, high levels of ferritin, cytopenias, and Kirtan also shared with us some supporting criteria such as conjugated hyperbilirubinemia and hyponatremia. And then we learned about Tafro syndrome, which is a variant of Castleman's disease, in which the patient presents with lymphadenopathy, anasarca, fever, thrombocytopenia, organomegaly, reticular fibrosis, bone marrow, and renal impairment. And so that was the final diagnosis. Thank you so much for attending today. Hope to see you tomorrow.